All right, I think that's it for me. So take it away, Ahmed.
Okay, thanks. Yeah, I turned off my video as well. I think I was a bit worried about the bandwidth there, but thank you very much, Jeremy, for the opportunity. I'm a bit nervous. As you said, it's a highly requested topic, so I'm going to try and do my best. And you had initially given me the topic, does this patient have HIV? False positives, elite controllers, post-treatment controllers, and I've been a bit of a fundamentalist. I've actually done it in that order, so I hope that's okay. But let's see if we can move these along. Let's see. By way of introduction, though, I wanted to sort of bring this article to everyone's attention. Not so hot off the press. July 1886 edition of the South African Medical Journal. But I thought it was a fitting introduction. And I'll just read the beginning part. So one characteristic of South African medical life can scarcely fail very forcibly to strike every observer. We refer to the constantly recurring instances of medical practitioners coming before the public in occupations other than that which ought their life's work. And it mentions that we meet with practitioners who are farmers in a more or less extensive way. And just by means of a disclaimer, I am a farmer. And it goes on to say that men are compelled in this country to diverge into so many different walks is a notable sign of the times and indicates a deplorable state of things fraught with evil alike to the profession and the public. So this article was shared to me with me by Dr. Juno Thomas. I think she thought it was quite amusing in terms of my current multiple vocations. And I'm raising it as a disclaimer. And if I am making any errors, as Jeremy said, please put it in the chat. Hopefully they'll come to my attention. And if you have any queries, please also raise them. There are a few issues that I'm going to touch on that are highly nuanced, and any people with very sharp eyes may pick up some specific on the diagnostics that I am going to present, and it would be great if you can let's say identify some of the nuance as and when we sort of hit them. Okay, so in terms of my background, though, I'm much more, let's say, familiar with pediatric HIV diagnosis or early infant diagnosis. And it was cases like this one that really piqued my interest. So this is a diagnostic case seen in Pretoria a fair while ago. But a lot of these issues are things that sort of are still very relevant. And it's essentially why I'm continuing to do what I do, which is to support diagnosis and pediatric HIV surveillance. So this patient is an HIV exposed child, and a birth test, a birth HIV PCR test was performed, and you can see it's at day 0. Let me put on my pointer. Okay, so day 0, this HIV exposed child is testing positive. The guidelines would be that you hopefully should be linked to care and initiated on therapy within 7 days of a positive diagnosis. But at that juncture, at that time of coming in for ART initiation, a sample should be taken for confirmatory testing. This confirmatory test came back as indeterminate, and the child then followed up at day 10, and the child tests negative. So essentially, those kind of cases are what really got me interested in the field. But the case that I'm going to present first today is actually an adult, and I would really appreciate any comments as we go ahead, any issues that let's say I potentially have glossed over, please do raise them. So this is a 22-year-old female client, self-referred for pre-exposure prophylaxis with a baseline HIV rapid test that is negative, and this is, the history is not entirely clear, but it's thought to be December 2022, with pre-exposure prophylaxis initiated at that point. Then subsequently, an HIV ELISA test is done. We think it's the month following that. We don't have a clear understanding of the reason why an HIV ELISA test was done, but it was done, and the ELISA is now positive. and the patient is started on initiation of TLD promptly. And then subsequently, the patient becomes pregnant and another ELISA is done. And it's not clear why this ELISA was done either, but it's now first trimester of pregnancy and it's the following year, January 2024, and the result is negative. Now, Jeremy said it's going to be bedlam if we ask people to unmute. I don't see anything in the chat group, but any comments on this? Is this a diagnostic dilemma?
So Ahmed, I'm gonna open up the unmute option to the audience. If you want to unmute, you're welcome to.
Yeah, so I've put diagnosis in doubt ? So the clinic staff were concerned about this. I think they were concerned that there was a positive and there was 2 negatives on either side of that positive. Okay, we're interested to know what the ELISA OD values are. Okay, thanks, Diana. Let me, if there's no other comments, let me just go on and go to what the actual guidelines state in terms of whether this is a diagnostic dilemma or not. Okay, so here are what the PrEP algorithm is. Essentially, sort of, you come for a rapid diagnostic test, and if it's negative and the individual client requests PrEP, then there's a little bit of screening that needs to be done. And essentially, if the client is eligible for PrEP, then you can start PrEP on the same day, and that client should come back after a month, and essentially they should be getting another HIV rapid test, and if they're negative at that juncture, they should be sort of followed up every 3 months. So in terms of HIV testing, the client is tested initially, then 1 month later, then 3 months later, and it seems like this client is following that sort of algorithm in the sense that they had a rapid test done at baseline, and then a month later they had a serology test on. It wasn't a rapid, it was an ELISA, but it is a serology test, and now that is positive. And in terms of the HTS policy, because that's what the PrEP algorithm is suggesting, follow the national HTS guidelines. So essentially, it's a 2-test algorithm that we currently have within South Africa. So if your first rapid test is positive, then you go on to have a confirmatory rapid test, and if that is positive, then essentially the status is HIV positive. There's a few troubleshooting that needs to be done if there's discordance, and essentially, if there is, then an HIV ELISA should be done. And the ELISA algorithm is pretty much the same. It's also a 2-test algorithm where you're testing, and if you've got a reactive on the screening ELISA, you do a confirmatory test, an alternative platform. And if it's reactive there, it's also an HIV positive test. So it's 2 tests for either an ELISA or a rapid test, and often the academic centers do still use HIV ELISA testing. It's, I think, from a budget point of view, it's a bit of a sore point because it's more expensive than the rapid tests, and I think there's it's often brought to my attention to try and support sort of quantifying the number of ELISAs done versus the number of rapids done in various regional hospitals or academic centers as trying to identify sort of unnecessary costs and reduce that. But essentially, the client would have had or followed the algorithm. So although I don't have the OD values, and that's certainly something to be able to be discussed, it's fair to say that if the client tested positive on screening and positive on confirmatory, that they are actually HIV positive according to the algorithm. Now, I'm raising this issue about 2 tests because I'm sure a lot of you know that as we are progressing with the national response to the HIV pandemic, the testing positivity is coming down considerably. So we have a population of around 8 million people living with HIV, and around 6 million have been diagnosed and are on antiretroviral therapy. Now, the World Health Organization came out with guidance for HIV testing services for a changing epidemic back in 2019, where they maintained that the algorithms should have at least a 99% positive predictive value using WHO pre-qualified assays, which have to be at least 99% plus sensitive and 98% plus specific. And they're obviously suggesting that the first test should be the most sensitive, and then the confirmatory test should be the highly specific test. But both of these are obviously going to be, all of the tests are going to be highly sensitive and specific, and that countries should move away from a 2-test algorithm and should actually endorse a 3-test algorithm if the positivity rate in the tested population falls below 5%. And the testing positivity in South Africa has fallen below 5% for quite a few years. It's variable, and obviously the data is only as good as the DHIS data, but it's somewhere probably around 3-4% currently, certainly not less than 1%. And that raises questions in terms of this positive ELISA. Could this have been a false positive potentially? Obviously, ELISAs are a little bit more sensitive and specific to rapids, but within this context of a changing testing population, a decreasing prevalence, could this have been a false positive? So I've tried with these, more specifically this case, I've tried to go through some general principles. So yeah, please excuse me if I've, let's say, oversimplified things, but I guess there's a broad audience here. So what a 3-test algorithm looks like, as opposed to that 2-test algorithm, is what I've just shown you. Is you do a first test. If it's positive, you go on to do a second test. If the second confirmatory test is positive, then you go on to do a third test. And all 3 rapid tests actually need to be positive for that patient to have a positive status. If there is discordance, essentially, if your first test is positive and your second test is negative, then you're supposed to repeat that first test. And, if it's positive again, and that second test is negative, then you can report that as HIV negative. But if the first test is positive and the second test is negative, then essentially, and that repeat is positive, then it's an inconclusive test. Now, on the third test, if you've got 2 positives and a negative, you don't actually repeat anything, and you mark it as inconclusive. So I've mentioned quite a few concepts in the previous slide: positive predictive value, sensitivity, specificity, just so that we're all on the same page. So the sensitivity of a test is the proportion of positive subjects classified as positive by the test. So, how the test performs essentially in detecting as many positives as possible. Specificity is the proportion of negative subjects who are classified as negative by the test. And then the positive predictive value is very different. It's the proportion of subjects who have tested positive who are truly positive. And similarly, the negative predictive value is the proportion of subjects who test negative who are truly negative. And you can work this out by a 2-by-2 table. So if you have a gold standard, you'll know all of those who are positive and all of those who are negative. And then you'll evaluate a test, and basically with this 2-by-2 table, populate who of those patients who are truly positive tested positive and who tested negative, i.e. true positives and false negatives. And then who tested positive on the test you're evaluating, but was actually a true negative. So that would be a false positive over there. And who tested negative and is actually truly negative, and that would be a true negative. And then you can calculate your sensitivities, your specificities, your positive predictive values, and your negative predictive values. So the important issue with what the WHO is saying is talking about positive predictive values and making sure that they are maintained above 99%, which essentially is saying that we do not want more than a 1% false positive rate. Okay, and the positive predictive value really is influenced by two parameters. It's influenced by the specificity of the test and the prevalence of a test. So if you have a test with a specificity of 99.9% and your prevalence is 20%, your positive predictive value rounded up is 100%. You're not expecting any false positives in that scenario. However, if you use that same test with a specificity of 99.9% and your prevalence now goes down to 1%, then your positive predictive value is only 91%, which means you're expecting a 9% false positivity. Okay, and this scenario, I've actually used those numbers because it actually relates to our early infant diagnosis, specifically at birth, where now our birth prevalence has actually gone down to around 0.7%. Okay, so this is the maths, and WHO has done it for a 2 and a 3 test algorithm. If the algorithm is simplified just to look at the consecutive reactive HIV tests. So if you take a population of 100 patients or specimens with a prevalence of 5%, you're expecting 5,000 positive patients or specimens and 95,000 negative specimens. And if you do one test in the algorithm with a sensitivity of 99% and a specificity of 98%, you're actually going to get a false positivity of 28%. And that's obviously why we sort of have a 2-test algorithm. And at this 2-test algorithm, so this is obviously at a prevalence of 5%, 2-test algorithm, you've got now a positive predictive value of just around 99%. But if you did a 3-test algorithm, your predictive value would go up to more than 99.9%. And this is why the WHO has been suggesting that we move to a 3-test algorithm, because below 5% prevalence, which is what we're seeing, you're going to have around 38 false reactives per 100,000. There's actually a paper online that's available that does the maths a little bit more comprehensively, and it then breaks down the numbers of false positives and the predictive values at 10%, 5%, 1% prevalence, and 0.5% prevalence. And what you can see is that the 5% prevalence, you've got 45 false positives per 100,000 tested, with a positive predictive value of over 99%, but then around 1%, not so many more false positives per 100,000. You've now got 47 per 100,000, but the predictive value is going down to 95% for a 2-test algorithm. And then at 0.5% positivity, you've only got a positive predictive value of around 91%. So the proportion of those who do test positive are more likely to be testing false positive. That's 9% false positive rate at the 0.5% positivity. Now, we've got a population of somewhere between 60, 70 million. Around 6 million are already on treatment. We hope that those people on treatment don't access serological testing again. Unfortunately, they are, and it causes lots of diagnostic issues. But essentially, you know, this 47 per 100,000 may not seem much, but if you're aiming to test the whole population every year, you know, that's 47 times 600. Even if you're aiming to just test half of your population, you're still going to be getting well over 10,000 false positives in the country per year. And if you're testing your whole population, it's somewhere in the region of around 25,000+ false positives. And obviously that's a big concern, and that needs to be addressed. As far as I'm aware, please correct me, anyone, if I'm wrong, especially on the chat. But as far as I'm aware, we've still got this 2-test algorithm since 2016. From my last interaction with Department of Health, I was told that they are going to be introducing a 3-test algorithm next year. It obviously has huge implications for the logistics and the procurement of 3 tests. Does anyone know anything more than I do? Is that correct? Does anyone use a 3-test algorithm or has used a 3-test algorithm? Okay, nothing in the chat. The one thing that is going to happen is there's going to be potentially a lot of inconclusives. So that's something just to bear in mind, because as I indicated on the 3-test algorithm, you're not necessarily, and I don't know how South Africa is going to introduce it, but you're not necessarily going to be repeating tests. Yeah, it then is going to open up potential diagnostic delays, which from a clinical point of view can be really, really difficult, especially if you're dealing with maternal patients, where you want a very clear result. You don't want to wait 14 days for a repeat test. You obviously want to clarify the diagnosis there and then. Yeah, sometime in 2024, maybe it will come sooner. I don't know. So let's see if the 3-test algorithm comes in, but it's going to raise issues, especially with the maternal population, where you obviously need to act not just for that patient, but also for the potential infant as well. Okay. So as you can see from positive predictive value, when you go below sort of 5% in testing of the positivity in the tested population, really sort of falls very, very quickly. Okay, so that brings us to our first case, and so we were contacted to assist with this case. So this is the patient who's sort of tested negative at baseline on PrEP, tested positive 1 month after being initiated on TLD, and then 1 year later, when she's pregnant now, she's testing ELISA negative. So we did some additional serological testing. Okay, so we did a 4th generation ELISA that came back negative, and then we did the equivalent of a Western blot. So we've struggled with getting the Western blot kits. They're often out of stock, but we've done something called a Genius screen, which is very similar. It identifies antibodies to various antigens. So here you can see that the GP36 is absent, the GP140 is present, GP31 absent, GP160 absent, P24 absent, and GP41 absent. So the GPs are the glycoproteins; those are the envelope antigens. P24 is GAG. P31, I believe, is integrase. So that's part of the pole region. Okay, so it's verified as indeterminate now. So, okay, you had a patient who was having discordant results, and now you've got an indeterminate, which probably isn't especially helpful. Just in terms of principles, so this is what a Western blot looks like. So it's a nitrocellulose strip, and then you've got embedded various antigens of various molecular size. So that's what the numbers refer to. So it often goes from the highest to the lowest in terms of molecular size. Sometimes I've seen it where it's actually broken up per region, but the GP, those are the glycoproteins, so they refer to the envelope. GP 160 and 120 are often considered one band. There's a bit of a smudge. Then P55, I think that's part of the GAG, but then P24 is obviously part of the structural nuclear capsid, and then P31 is part of the integrase region. Okay, so that's what a Western blot looks like, and it's not used routinely anymore. It's fallen away. It was obviously the mainstay of diagnosis very, very early on in the pandemic, but was replaced by other serological testing like ELISAs and the rapid tests. I want to show you what a gen screen then looks like. It's very similar. It's broken into bands. Gen screen also tests for HIV-2 antigens. Okay, so those are the various bands. And our patient came up with GP140 only. Okay. And in terms of these interpretations of Western blots, I don't know where I got this slide from. It's a very old slide, but you can see it breaks down how the Western blots are interpreted according to the various antibodies that come up positive. So in the African region, we've often said any two of the envelopes are considered positive. In our NICD SOP, we actually consider sort of GP 160 and GP 120 to be one band only. So you're going to have to be testing positive for GP 41 as well, other than those two. But there's obviously various combinations which would be considered a positive, and then an indeterminate would be one or more bands that are present, but doesn't meet the criteria for a positive result. And often we're the only, as far as I'm aware, in this part of the country, the only NHLS lab that does these tests, and often they're requested to try and support a diagnosis. So in this particular case, I don't know if anyone thinks that is particularly helpful. Looks like an HIV-2 band, likely to be dodgy. Thanks, Diana. You've got very good eyes. So I'm glad you picked that one up. So that is that's one of the little items that I wanted to was hoping someone would pick that up. So it is a bit dodgy. I mean, it's verified as indeterminate. And it's, as Krishalin is saying, it's strange that you've got this negative on the fourth generation as well. Okay, so that's great. Thanks for picking that up. So we also did a molecular test. Okay, I'm not making this up, by the way. This is a real case, and I'm hoping Dr. Ninka Fari is joined us because she referred the case to us, and then I'm hoping Dr. Maria Paximadis is also on the call because she was also involved in some of the testing. So the PCR result is indeterminate. Okay, now I'm going to touch on what we've been trying to achieve with the various sort of molecular assays at NICD in a bit, but in terms of what an indeterminate PCR is, it's based on criteria actually from early infant diagnosis cases, and this is work done by Jean Moritz in Stellenbosch initially, and looking at whether patients who have high cycle thresholds are reproducibly positive on that sample, as well as on follow-up, whether those patients are still being detected HIV positive subsequent to that sample draw. So he did two papers looking at this, one where they repeated on the same sample, and essentially what they found was where the cycle threshold was above 33, those patients were more likely to test negative on repeat testing of that sample, but also when the patients actually came back for follow-up, they were more likely. Initially, he also described this with a fluorescence intensity of more than 5 or less than 5. And this is what was used within the NHLS on the older assay, the CAP-CTM version 2. These thresholds were actually used. For those who aren't that familiar with what a real-time amplification curve looks like. So this is a real-time PCR where you are amplifying and detecting at the same time. There's two sigmoidal curves here. The one is the internal control. Okay, so that's the QS, and it's saying cycle 27. So that means it basically picked up above the optical density for detection at cycle 27, which means that it was clearly positive. It clearly got detected. So PCRs, just to recap, there's 3 stages. There's a denaturation step. There's an annealing step where the primers join, and then there's this extension. And essentially, those 3 steps are considered one cycle, and then with real time, you're extending or amplifying at the same time as detecting. So this is replication of sort of denaturation, annealing, and extension, and then it happens again and again and again, and eventually you're going to get, if there is amplification, detection. So what it means is the lower the number of cycles, the higher the target material, the higher the concentration of the target material. So here, the actual target, which is the the square blocks over here, the cycle is 24.4. Sorry, it's the diamonds is the actual target here. So this is the patient specimen here, and it takes off at around 24 cycles, or a cycle threshold CT value of 24, and that's what a clear positive looks like on this assay. Qualitatively, the indeterminate looks very different, right? So this is the internal control over here, nice sigmoidal curve, and over here the cycle threshold is 34.9, and that, according to the SOP in the lab, would have been interpreted as indeterminate. So just to clarify, these tests, the instrument will say HIV detected. It's then interpreted within the lab as either positive or indeterminate based on certain criteria. Currently, it's only cycle thresholds that are used on the newer Cobas assay. The older assays provided these real-time graphs, so you could also read the fluorescence intensity, which is really a marker of probe efficiency. But usually, fluorescence intensity and cycle threshold are concordant. Low sort of a high cycle threshold, low fluorescence intensity, and vice versa. Okay, so this is what the patient's results actually look like, and we didn't just do one PCR test here. We actually did 20 PCR tests, and I'll go into detail why we did that if I get time enough to go through the second case. So we did a commercial assay. We actually did 19 tests on the commercial assay, 19 replicates. 17 were negative, 2 were detected with an indeterminate threshold, which is these results. We also did an in-house DNA PCR targeting integrase. This commercial assay targets GAG and LTR. So slightly different targets. All 20 of those were negative. Okay. So that's part of the molecular picture. Anyone who's, you're welcome to put also in the chat, is this potentially just an issue again of a positive predictive value, which is low, and then you're going to be getting false positives, or a higher number or proportion of false positives. I want to touch on something else with regards to molecular interpretations, and that's viral load interpretations. And the reason being, I think these are often confused in the field with regards to how to interpret a viral load result. And pretty much all the package inserts have the same kind of 4, let's say, categories of results for a viral load. You've got target not detected, which essentially is for a viral load, no RNA detected, and essentially that is interpreted within the NHLS as less than the detectable limit. So you'll see on TrackCare LDL for target not detected. That's quite different to when you get that less than sign. I don't know if anyone's aware of that, if they see the less than sign, because you often will see a result that less than 20, less than 40. If you're a pediatrician or seeing pediatric patients, you'll often see less than 100. Yeah, I don't know if anyone's seen that. There's obviously, the instrument is trying to make a point that there's a difference between these two, qualitatively speaking. The other results would be anything that's quantified, from more than the lower limit of quantification to the upper limit of quantification. And then there's an upper limit of quantification, which is usually above 10 million. So this is what the old CAP-CTM package insert looked like. What the NHLS is currently moving to the Alinity. I believe all viral loads from July going forward will be done on one assay. Previously, Abbott and Cobas were both doing viral loads, but I think from July this year, it's only one assay, but it's the same story, right? In terms of not detected being different to that less than sign. And essentially, if you go into these package inserts and you look at it, that less than sign is actually saying the RNA was detected. So qualitatively, that's very different from no RNA. And I'm bringing this to everyone's attention, especially in the pediatric population, where samples are usually diluted in a 1 in 5, which means that if the lower limit of detection or quantification rather of the assay is 20, and you do a 1 in 5 dilution, you actually no longer saying it, you can't say less than 20, you have to say less than 100 copies per mil, because you've diluted it 5 times. So you multiply that essentially lower limit of quantification. It's often confusing to the field because our lower limit of suppression is 50 copies per mil. And now those less than 100 are often treated as actually low-level viremia, which is difficult to entirely say what's going on. And on tier.net, I think they're even sort of entered as 99, I was told. So anyway, I'm raising it for 2 reasons, really, in terms of care. I don't know if there's clear guidance from the lab in terms of how to interpret the less than 100, but I would probably, I'm not a clinician, but I would probably think that it would be safer to interpret less than the 100 as actually virologically suppressed as less than 50. It's quite difficult, I think, to flesh that out. The other is qualitatively, if you get a less than sign, the instrument is saying HIV is detected, RNA is detected. It's just that there is a difference between the lower limit of quantification of an assay and the lower limit of detection. So what you're presented with is generally a very accurate sort of level of quantitation between 20 and 10 million copies per mil. Less than 20, usually the diagnostics, they go to somewhere in the region of 16 copies per mil. It's not going to be able to quantify it accurately, but it is able to detect it. Now, obviously, your accuracy at that very low limits is not the same kind of accuracy at higher level. So your qualitative PCR, the lower limit of quantification is around 350 copies per mil, at least on the Cobus Cap CTM version 2. So it's got a higher lower limit of detection, and that's partly because you're also testing whole blood with inhibitory substances, whereas on viral loads you're actually testing plasma. So analytically it's more sensitive. So if you're using viral loads to support, on plasma at least, to support difficult diagnostic cases, just be aware of this, because qualitatively the assay is saying detected. Okay. So that brings me to controllers. So HIV controllers, they're a heterogeneous group associated sometimes with protective HLA alleles like B57, which I think is the same allele that's responsible for hypersensitivity to Abacava, which means we don't really have that in South Africa. If I stand to be corrected, please on the chat correct me if I'm wrong there. Also, potent T-cell responses have been associated with controllers, and as well as patients who have relative, or their CD4 cells and macrophages have relative resistance to HIV. And then obviously there's defective variants of HIV as well that can account for controllers. So usually these are put into 2 groups. You've got your non-viremic controllers and your viremic controllers. And your non-viremic controllers sort of usually have an undetectable virus, so lower than what your standard assays can quantify or detect, and occur approximately 1 in 300 people living with HIV, with a median viral load of 2 copies per mil, and disease progression with CD4 cell count decline is unusual in this group, and that's compared to your viremic controllers, which usually have a viral load of less than 2,000 but more than 50. For our region, there was a report this year that came out from the pop-out study from participants in Zambia and South Africa, quantifying viremic controllers about 3%, suggesting that it could even be higher. And disease progression with CD4 count decline is more common, and often you'll get CD4, CD8 inversion with these cases. Okay, so the definition of these controllers is usually also taking cognizance of the duration of control. So usually, there's different definitions that have been used, but 2 or more viral loads below 50 for a year or more in the absence of ART is often used. And that's important because you often do get patients who are able to spontaneously achieve at least one viral load below the threshold of detection, and up to a quarter of HIV positive patients or infected patients can actually achieve a spontaneous clearance at least once, and just around 9% can achieve consecutive viral loads at around this threshold. In terms of the clinical relevance of this, I don't think the national guidelines even mention elite controllers, because you've got a sort of a test and treat approach. But the South African clinician guidelines do, and it suggests that all patients who are HIV positive are initiated on therapy for various reasons. It's quite an interesting, I think, discussion point. I don't know, Jeremy, if this comes up regularly, because you will get people who will say that you could potentially flesh out this group, and I know there's various issues with continuous low level replication, especially below like one, 2 copies per mil. But there has been some new, let's say, reports on this. But be that as it may, there's this one pitfall that's noted in terms of just make sure that it is truly an elite controller before you diagnose and treat. So that's 2 groups of controllers, viremic and non-viremic, but actually there's a growing group of post-treatment controllers. And a lot of the evidence had sort of come from patients on PI regimen. Thankfully, there's more evidence, recent evidence on patients who are on an integrase, a strand transfer inhibitor, an integrase inhibitor. So usually, if you stop treatment, you're expecting rebound within 4 weeks of discontinuation. Amongst patients on dolutegravir, the study found that the median time to viral load rebound above 1,000 was 22 days, with quite a sizable range of 13 to 230 days. Interestingly, no difference has been found with timing of viral rebound with the integrase inhibitors versus PI-based regimens. It was a very nice paper, this one, that came out a few years ago. Lower pre-ART viral load is associated with more delayed viral rebound, and that's possibly sort of related to reservoir size. But very importantly, early ART initiation was associated with significant delay in time to HIV rebound after ART initiation. So it's not the regimen, but essentially if you're testing and treating and detecting early infection, and that's defined as Phoebig stages 3 to 5, then you are going to expect a delayed time to viremia with treatment interruption. And that's a really important point, I think, to be aware of. In terms of Phoebig stages, I've just trying to provide sort of some sort of learning. Phoebig stages are described 20 years ago. They're related to essentially the various assays that were available, but also biomarkers, and when they come up in terms of RNA coming up first, and then sort of P24 antigen, and then antibodies and certain markers of your Western blot as well. So they used sort of 3rd generation HIV ELISAs here, and essentially what we're saying is stage 3 to 5 is essentially sort of a period of around 2 weeks to around 3 months. So that's how the study defined acute infection, about 2 weeks to 3 months after infection. If you initiate ART in that window period and you are going to perform treatment interruption later on down the line, expect some delays. Just in terms of the generations of the assays, so I've mentioned 3rd generations and 4th generation. So currently within the NHLS, we use a 4th generation. That essentially is a test which is able to detect antibodies, both IgG and IgM, against HIV-1 and HIV-2. It's also able to directly detect P24 antigen, but it doesn't differentiate between any of those. 5th generation ELISAs are able to differentiate. They're not more sensitive or specific as far as I'm aware. They are able to differentiate HIV-1 from HIV-2, and they're also able to sort of detect directly detect P24 and differentiate that from antibodies. I'm not aware of any NHLS test or NHLS lab that does 5th generation. I think they had registered or logged them on TrackCare. But yeah, please, again, if anyone is aware of a lab that does a 5th generation, please let me know. In terms of this patient, maybe it would be nice to be able to do an assay that would, differentiate HIV-1 from HIV-2, albeit you may not have the opportunity to detect any antibodies anymore because the patient's on antiretroviral therapy. But you've also got other assays which could potentially differentiate, like an HIV-2 specific Western blot. We use HIV-1 specific Western blots routinely at NICD. You also have the multi-spot test, which I don't believe is very sensitive. So, okay, that brings us just to go through this early ART initiation. So a higher percentage of early treated participants remained off ART at post-treatment interruption of 12 weeks. So that was 9% of your patients treated during acute HIV who were off treatment at 12 weeks. And then sort of, yeah, in terms of the rate, so 3% of your chronic treated participants versus 8% of your early treated participants, regardless of regimen, were found to essentially be suppressed at week 24 post ART. So that's considerable. Half a year off ART and 8% of your acutely treated patients are actually, let's say, still controlling. And interestingly, the patient that is described in the study was not a controller. They had a baseline viral load of 1.4 million. So this is not a controller, essentially. This is someone who was extremely viremic, who is able to control, not because of the specific regimen or some HLA type, but likely because of acute or treatment during acute HIV infection. Okay. I'm going to run out of time, aren't I, Jeremy? I don't know. Can I have another 5 minutes or so?
Yes, absolutely. Yeah, no problem.
Okay, because I don't know. I think normally you have some questions as well. Okay, so modern ART regimens, they're obviously not able to achieve remission more than the other regimens in the past, but early treatment essentially does, and I think that's the point to have. Okay, then in terms of other controllers, so I've gone on to treatment, but pre-exposure prophylaxis and post-exposure prophylaxis can have the same effects, essentially, that they can alter detection of various biomarkers, whether that's RNA or proviral DNA or HIV or anti-HIV antibodies. Okay, there's nice reports early on oral PrEP, as well as in injectable cabotegravir, where diagnosis was found to be extremely challenging for some of those patients who did actually seroconvert despite exposure to cabotegravir. So essentially, we're in sort of a bit of a pickle where we're trying to diagnose secondary to trying to prevent infection, essentially. Okay, I'm going to skip this go over this maybe very quickly, but obviously there's quite a lot that's happening immunologically with HIV infections in terms of CD4 counts declining and CD8 counts increasing, and looking at that CD4-CD8 ratio, because we're clutching at straws in terms of nucleic acid testing and serology, and then you do have some immunological markers which potentially could support diagnosis. So just to bear in mind, though, that a low or inverted CD4-CD8 ratio is not a phenomenon specific to HIV-infected populations. Okay, so although it's not found to be a marker of morbidity and mortality in all populations, it seems to occur consistently in SLE patients. It also increases with age. So, for instance, patients above 60 to 95 years of age, 16% of our population will have an inverted CD4-CD8 ratio, whereas only 8% in the 20 to 60-year age group. But it could potentially be helpful. Okay, so lower CD4-CD8 ratios during treatment do predict residual viral replication. So again, if you've got controllers and they have a normal CD4-CD8 ratio and they're confirmed to be infected, it does raise questions, would you potentially want to defer treatment? There is found to be an increased morbidity and mortality with HIV-positive patients who don't normalize their ratio, and obviously a patient who is suppressed but still has an inverted ratio, especially sort of years after ART initiation, that is a concern for that patient. And I think the take-home point is that there is evidence to suggest that inverted CD4-CD8 ratio could be sort of proportional to the HIV, or inversely proportional to the HIV reservoir size. So a smaller ratio, a larger reservoir size. Still really to be confirmed, but there's some evidence to suggest that. Okay, so yeah, going back to our case, I don't know, to be perfectly honest. Is the diagnosis still in doubt? So just to confuse everyone further, I'm going to try my hand at some Latin. Entia non sunt multiplicanda praeter necessitatum. Okay, which means entities must not be multiplied beyond necessity, which in common English would be the simplest explanation is usually referring to Occam's razor or the law of parsimony. This patient has tested on multiple different assays HIV detected, including different serology assays, as well as a molecular assay. Are you seeing false positives in all of those cases, especially under the context of, let's say, antiretroviral therapy that was initiated after an ELISA? It obviously raises questions in terms of the value of doing baseline viral loads. It raises the question of doing not just CD4 tests, but actually CD4-CD8 tests, which we don't routinely do in the NHLS. But it would be really nice to hear back from anyone who's joined. So I apologize if I'm not able to give any clear, let's say, I don't know, feedback. We obviously are suggesting that this patient continue on ART during pregnancy, where we'd like to repeat the testing on multiple different assays, as well as change the target for the nested PCR assay. But yeah, I think just in terms of a summary, then a decreasing HIV prevalence in the tested population is resulting in a decreased positive predictive value of HIV assays. We can't exclude HIV infection, however, within the context of suppressive ARVs, and that includes, vertical transmission prevention and PrEP regimens and PEP regimens. And essentially, that's going to result in HIV diagnostic dilemmas that are set to increase, both in terms of the increased proportion of false positives. Hopefully, new testing algorithms support that to decrease the likelihood there. And then the increase in the number of false negatives, however, is going to occur. We desperately need to improve treatment literacy. We desperately need patients on ART to know that they shouldn't be having HIV tests, and that negative results, essentially, under the context of ARVs, cannot be considered to suggest sort of HIV uninfected status. And then we need to new novel approaches to diagnosis, and that includes new biomarkers and new algorithms. And I do have another case, but I have a feeling I may have gone over time or be going over time. So is there anything in the chat box, Jeremy, that I should be aware of? Do you want to open it up for the chat? Should I go to my second case? I don't know.
Ahmed, I think this is really important. So I think go to your second case, if we can do it, say, in 5 minutes, and then we'll take questions afterwards, even if we're a little bit over time. I'm okay with that.
The second case relates to why we're doing crazy number of replicates. So this is a child who's HIV exposed. Birth test was indeterminate. That's on one test before we went crazy. And then the confirmatory test 7 days later is also indeterminate. Okay. So diagnosis in doubt, it's if you follow the guidelines, just like if you followed the guidelines for that first case, the diagnosis is not in doubt. So the guidelines state, and this is from 2019, and it's in the current VTP guidelines, if you have an indeterminate PCR result, check the prior HIV PCR result. If your prior result is positive and or indeterminate, or you've got a detected viral load, then you should treat that patient as HIV positive. Okay. Despite that, obviously, I can understand clinicians are uncomfortable with telling a patient that you're HIV infected if you've got an indeterminate result that was verified. It has obviously huge implications. And I do understand that further testing was done and the diagnosis was considered to be in doubt. So at day 9, you've got a viral load down. It's 110 copies per mil. There used to be huge concern with, sort of issues with low-level viremia and accuracy, especially if you're using this as a qualitative interpretive result, because of problems with contamination, whether that's cross-contamination or carryover contamination. The assays have obviously improved considerably and are now closed systems. And I think low-level viremia, I know we've had problems in the NHLS, but that was specifically pre-analytical problems with recentrifugation of samples that weren't stored optimally with delays. So analytically, the low-level viremia should be accurate as long as the sample is handled properly. But at day 9, 110 copies per mil. Day 12, now you're negative. It's like that first case that I presented where you've gone from sort of HIV detected to negative within a fairly sort of brief period of time. In terms of the history and the maternal history, as a 25-year-old maternal patient who was first tested during her pregnancy during first trimester, testing positive and initiated on TLD. Unfortunately, she says she wasn't aware of the pregnancy, so didn't actually book antenatally, and that obviously talks to how our health services need to be integrated. At delivery, the maternal viral load was 97 copies. CD4 count was fairly low, 291. Infant was born prem at 35 weeks, low birth weight, 2.1 kilograms, put on high-risk prophylaxis, which is probably relevant. Certainly, we found that those cases that have early loss of detection are often high risk and are on a dual prophylactic regimen. And the patient was formula fed from birth, so no subsequent HIV exposure other than at birth. And then at NICD, and this is Dr. Maria Paxamatis who really suggested, let's just look at testing more blood volume. So we've got 2 assays where we use a reservoir assay, which is a research assay, essentially a nested proviral DNA HIV-1 assay. We did 15 replicates on this assay, and we did 15 replicates on the commercial assay, and then 24 replicates on this in-house assay, which I've alluded to already. So this is costly, but we obviously think that the reservoir is so small that it could very well be random in terms of where HIV pops up. And if you're just testing 100 microliter sample, which is what we often do, the chances are if it's a random distribution, you may very well get a negative result. So over here, the 15 replicates are what we got. So we got 7 positive results, 4 indeterminate results, and 4 negative results. So 1 patient, 1 sample is testing positive, indeterminate, and negative. And this is really suggesting that the reservoir is tiny and that it's random. And that if we are getting patients who test indeterminate, we're going to struggle to actually provide an accurate diagnosis on a very small volume of peripheral blood. In terms of the nested real-time PCR assay, the 24 replicates, so integrase region was tested as well as reverse transcriptase, and on the integrase region, 10 of the 12 replicates were HIV detected, and on the reverse transcriptase, 6 of the 12 were detected. I'm not so sure. Maria tells me she doesn't think it's to do with the primer or the target. Yeah, we're obviously gonna have further look at this, but yeah, essentially, if we are going to improve diagnostic accuracy, we need to start thinking out of the box. And one possible way is, just test an increased volume of blood by multiple replicates on a commercial assay, or use a research assay which potentially has a higher input volume or a lower limit of detection. With early infant diagnosis, we are seriously facing problems. So of the HIV detected results, so that includes positives and indeterminates that are verified, 31% of the detected results at birth are actually verified as indeterminate, which is not great. And that goes down with age, and that's probably associated with a whole host of reasons. So yeah, I'm not going to go into that in too much detail, but my summary remains the same. We're a bit stuck, and really need to improve patient literacy, or treatment literacy, in terms of what these assays now mean within the context of ART. I mean, when we started doing this work, it was really focusing on pediatrics, and now it's very clear that the interaction between antiretrovirals and diagnostic accuracy is for all populations, and with PrEP it's even more relevant. And we need to start thinking out of the box with novel approaches. So thank you very, very much. I hope everyone's come away with at least something. And just to thank Dr. Maria Paximadis, Dr. Ninka Farid, Dr. Shiva Varangis, Prof. Kurt Vinsel, Prof. Mark Cotton, Prof. Caroline Timerson, Dr. Tanya Murray, and Mr. Dumasani Mlachwa. Thanks very much.
Thanks so much, Ahmed. That really was fantastic. Lots of conversations going on, lots of messages going through. I just wanted to focus on one or two questions in the chat, if you don't mind, and appreciate to the audience. I know we've got a little bit over time, but this is really important, and Ahmed's done such a great job with it. One question that came up twice was about do we have any sense of which assays the DOH may choose with their three-step algorithm? Will it be sort of three rapids, or and different manufacturers, or is there any other nuance that they'll head with?
So thanks for that question. It's a great question. So some of the labs were actually doing viral load testing as a confirmatory test a while ago. I don't believe Department of Health would do so. I believe it's a three-test algorithm with all rapid tests, and the sensitivity and specificity of each of these tests would need to be above 99 and 98% respectively. So all tests would have to have a sensitivity of more than 99% and a specificity of 98%. I do foresee big challenges with a lot of indeterminates and repeat the test later on. I don't know how we're going to get around that. It's going to be interesting to see what Department of Health comes up with in terms of the HTS algorithm.
Cool. And then the last question really is about this cabotegravir issue, and we anticipate increasing numbers of people will be put on it for PrEP, and then the issues around that in terms of the diagnostic algorithm, I guess. Do you have any sense of, because there's obviously these issues where in the trials the viral load was pretty good at picking up the HIV, but not so much the other tests?
I don't know much detail. I think it's worth reaching out to HPTN 084. I don't have more details. I mean, I haven't had actually a very comprehensive look at that paper. I know has been discussed in various forums. I was expecting further papers actually on this. I don't know if anyone has come across anything further. But from my side, yeah, it would be really nice to hear back from them in terms of what their suggestions are. I don't have any anything further to add, I'm afraid.
Great. Well, thank you very much. And I think there's I think for most people watching this, I think you get some sense of the potential complexities. It's nowhere near as simple as the guidelines make it ever. And we're very grateful to have people like Ahmed and the team at the NICT to help with these sort of questions. They are very, very difficult in some instances, and you've shown us two such cases. Thank you very much, Ahmed. I hugely appreciate it. If there's any other questions people didn't, I think I've gone through them all, but if there's anything else that you want to ask, just add it in the chat. And if Ahmed is around, he can type them in there. Otherwise, I can pass them on to him afterwards. So thank you so much again, Ahmed.